The next session will be over the tongue and the hypopharyngeal lesion, and moderator will be Colonel Vikas Sharma, and the faculties are Dr. Indranil Pal, Dr. Sudeep Kumar Das, Dr. Ranjan Roy Chaudhary, and Dr. Shubhadeep Karanjay.
Hello, nahi aa rahi. So, I have two requests. Number one, I want all of you to put down your pens and pencils and close your books. Do it right now. I'll tell you why. Dr. Indranil sir told me a wonderful thing before we were to start this session. This is basically us leaking a paper for you. There is nothing you are going to be asked in exam which we are not going to ask today. Not only are we going to ask you questions, but as me and my team, we have sat down for last couple of weeks and made every single question with evidence what you need to answer in exams. We will provide this to you at the end of the class. So essentially, there is nothing that I am going to ask today that you do not have a ready-made answer for. So nothing to be written. Only listen and answer.
Our WhatsApp group, we will share all the question answers.
Today, Dr. Sudeep Das will be on history, Indranil sir on examination, and Dr. Karanjay for investigation and management. Nobody is going to be left alone. We are going to ask questions to every single one of you. Pay attention, right? So I am Dr. Vikas, and we are going to be doing a representative case of carcinoma tongue. So when you say patient introduction, just keep standing, keep answering. If you do not know the answer, don't be flustered. The next one stands up. I don't know who is a faculty here, who is a student here. So if I mistakenly ask you, please do tell me. Start. So how do you introduce a patient when you come in front of a examiner, right? So my patient, say something. Will not waste too much time. And you are addressing Dr. Sudeep Das right now. He is going to give you the model answers of what you miss.
Introduce myself and take the patient consent for examination and history taking, and ask the patient.
You are sitting in front of an examiner. Sir, my patient, Falana Dhimkana, and then you start to rattle out a couple of words.
First patient particulars, name, age, sex, religion, occupation, date of admission, date of examination, and then chief complaint, followed by history of present illness and past illness.
No, bas, enough. Introduction. Sir, anything that is missed, sir? What all to say? So,
my patient, Mr. X of dash years, came from this village or something with this occupation and presented to the OPD with the chief complaints of any swelling in the tongue with the duration should be mentioned, and any other chief complaints related to that swelling or the ulcer.
So essentially, you have presented a complaint in a chronological order of a person whose name, age, socio-economic status and a place of staying you are aware of. That's it. Next person. So your patient has now presented with a non-healing ulcer and some kind of pain on the tongue. Now history of present illness. What do you ask this patient? Essentially you are doing. Kya likha beta? All you have to do is read on the slide.
Yeah, detailed description of chief complaints.
Which are?
My patient was apparently well before.
Apparently well. Your chief complaints were pain and
swelling.
Ulcer and swelling. So how do you now describe a ulcer?
In this type of ulcer, or in some case of swelling also, like previous case of thyroid, in most of the cases patient suddenly noticed. So as such to start with, the patient suddenly noticed an swelling or ulcer in the such area of the tongue after an episode of tongue bite or self-examination. Most of the cases insidious means the onset of the ulcer, patient cannot say yes there is small ulcer, then it grows. In most of the cases, when first notice is a half centimeter or 5 millimeter or 1 millimeter size, suddenly noticed during self brushing or during any bleeding during brushing or during accidental cheek bite, tongue bite. So better to say in most of the cases, patient suddenly noticed and so an ulcer in the lateral border of the tongue when he done brushing and noticed some bleeding. And then the duration comes, because not from the very beginning, when it is up 1 millimeter, patient will notice not that. Patient noticed when it was 5 millimeter, 7 millimeter, 1 centimeter. So he noticed back, and then the duration of the ulcer.
So you've now described the ulcer, right? The next person, read out what's on the slide rapidly. Jaldi jaldi padho.
It's a non-healing ulcer which is insidious in onset, progressive in nature. Duration is of 6 months, which occurred in the right lateral part of the tongue. It occurred due to trauma following tongue bite, and it was associated with pain and occasional bleeding.
So you've started to make a transition onto the next chief complaint, which was pain.
The pain.
Right? So you have to
And
say
one thing,
that-
sir, one thing regarding the ulcer, you must mention the initial size when he first noticed. Because he noticed 6 months back it was a 2 millimeter, 2 millimeter or 4 millimeter size. Now it is 10 millimeter, or if it is 2 millimeter then and now it's 3 millimeter, the significance is different. So you have to know when he or she first notice the swelling, what is the size, what is the present size, and the rate of the growth. What are it is growth, uniformly growth from 2 millimeter to 4 centimeter uniformly, or for the past 5 months it was very slow growing, then suddenly rapidly changed the size of the growth in the last 1 month. So it may be a benign or intermediate nature in the beginning, and last 1 month it transforms into the malignancy. That's why the swelling rapidly grows into in the present size. So total duration, what is the present size to past size, past notice size to present size, and the rate of the growth. Very important, the history to know the nature of the swelling.
Next one.
Patient approximation patient, so it was size, it measures in the millimeter, or sometimes in a comparison it is size of a peanut, size of a almond, size of a patient wants something, it was size of a peanut. So in the swelling peanut, it gets in a groundnut, in the shape of a, like that.
So
Sometimes
these are
patient like that.
anecdotal. See, whenever we are telling you all this, na, peanut, non-peanut, falana, lemon, my lemon may be bigger, yeah. So thing is, these are anecdotal teaching. Anecdotal क्या होता है? मैं क्यों पढ़ा रहा हूँ? Because मेरे teacher ने मुझे पढ़ाया था. There is no evidence to it. So ऐसा कोई hard and fast rule नहीं है that you have to say these specific words only. Whatever seems comfortable to you. It's an anecdotal teaching, right? But you have to mention the size in one way or the other. The next one is pain, right? So now you describe the pain. But remember, whenever you are uttering these words, there is a reason to every word that you have uttered. We'll come on to that either in the lecture that I have already given to you people, or we can discuss it one by one as well.
We
Pain.
now describe the pain, which was insidious in onset, non-progressive in nature, which was intermittent and was of burning type. It was of mild severity and was of 6 months duration. It was more pronounced during the movement of the tongue. It was radiating to the right ear, and it was aggravated with spicy foods and relieved with medication.
So essentially, every single thing that was associated with pain, was it staying there, was it radiating somewhere else, something was aggravating it, something was relieving it. Next person. So radiating to ear means referdotalgia. What would be the, so now the next question that I am going to ask you, if I am going to give you distinction, is what is the efferent and the afferent pathway for this referdotalgia?
Afferent through the glossopharyngeal nerve, efferent, no.
Which nerve come in front of the ear?
We don't, so again, it's not a viva. I am not trying to judge तुम्हें आता है कि नहीं आता है. I am trying to teach, right? So आता है, very good, नहीं आता, next. Mike.
Afferent by the carotid nerve, by lingual nerve.
Afferent, efferent. Efferent is exit. How something is going to exit from the brain. Afferent is how it's going to go towards the brain. So how does pain go towards the brain? And then something takes it away from the brain. So afferent क्या हुआ टंग में?
Glossopharyngeal or lingual.
है ना? And अगर बेस टंग है तो glossopharyngeal. और efferent क्या हुआ? How does it come back to the ear? There has to be only one method. अगर glossopharyngeal है तो Jacobson. And if it is lingual, then via the trigeminal it goes back to auriculotemporal and come back to the ear. So you have to know the afferent and the efferent pathway. What next? Next. So now when you are dealing with the patient of head and neck cancers, You've asked for pain, you've asked for ulcer. और क्या पूछना है? ये this is true for every single case of head and neck cancer. क्या basic questions पूछने ही पूछने? Cardinal symptoms. Next. It's okay.
Associated with any hoarseness or voice?
Hoarseness.
Any
I have one request. I have told this to every single person I have ever met in my life. I will tell this to all of you. Remember this. Is there any other sound in the body which can be hoarse? Do you say, I am deaf in my ear? Do you say, I am blind in my eye? When you say you are hoarse, it has to be hoarse. So you never say hoarseness of voice. I am blind in my eye. Doesn't make sense. You say the patient presented with hoarseness. It is understood voice का ही होगा ना?
Sir, one thing regarding pain, in many cases, patient may present with the burning sensation or sometimes we do the mucosal ulceration and so, but in many cases that phase is over. When patient came to us, that phase is over and due to malignancy, the nerve ending was blunt. So at that phase, there will be no pain definitely, but or deep boring pain may present with. But burning sensation over. From the patient very beginning, it is burning sensation. Later, burning sensation over due to blunting of the nerve. Then, if involving the deep part, the deep boring pain.
What else? What have I missed? What should I have asked to the patient? What are the other cardinal features? It's written there.
Nature of the ulcer.
Ulcer हो गया. Ulcer हो गया, pain हो गया. Hoarseness मैम ने बता दिया. What next? सामने लिखा है.
Dysphagia.
Dysphagia. What next?
Odinophagia, and there is also in malignancy loss of weight and all we can ask.
Those are not cardinal features. Those will tell you about the nature of the disease, aggressiveness of the disease.
Dyspnea.
So these are the 6 things you always need to talk about. What are the ones?
Non-healing ulcer, dysphagia, odinophagia, dyspnea, neck swelling, speech and voice changes.
Speech when there is a problem with articulation. Voice when there is a problem with larynx. Next. What else? What else do we need to ask? What positive history? What negative history? Tell to sir. Mic.
Regarding the ulcer, no?
Regarding a patient presenting with oral cancer to you. We have seen the ulcer, we have seen the pain. Now what else am I missing? और क्या पूछना है positive और negative history में?
So we need to backtrack for the neck nose whether there is any neck nose. Achha.
We've already done neck nose.
Achha, you are
Talk into your mic.
Achha.
Next. It's okay. Rapid. We are short of time.
So in positive history, we have to ask any familial history or radiation history of difficulty in speech for 2 months, any history of excessive salivation present, history of bad odor from mouth present, history of loss of weight present due to reduction in food intake, is there any history of dysphagia, neck swelling, history of no history of dysphagia, okay, no complaint of restriction in trunk protrusion. If there is any history of teeth loosening or gum bleeding, any history of loss of taste sensation or history of swellings or lumps in any other parts of the body, history of fever, jaundice, difficulty in breathing, recent onset bony pain, any history which is suggestive of other complaints related to ear, nose or throat.
The easy way to rectify these is understand the logic behind it. Okay? What would be the logic behind all these? Rapid fire. One is the primary pathology in the oral cavity. Right? Second, और क्या बोल रहा है वो? Difficulty in speech, मुंह में कुछ था. Excessive salivation because swallow नहीं कर रहा है. Next, bad odor, halitosis है because yes, loss of weight because dysphagia, neck swelling we've done. No complaints of restriction of tongue protrusion.
Base of tongue involvement.
Excellent. Loose teeth, gum bleeding because floor of mouth, alveolus. Next, loss of taste sensation, nerve endings. Swelling or lumps in any other part of the body? Any other part of the body?
Distal metastasis.
Lymphatic plus
distal mist. Distal meds, sir.
Distant meds or a different etiology altogether. We may be dealing with something completely else. Fever, jaundice, difficulty in breathing, recent onset bony pain, meds. And last is other complaints related to ENT. We should always talk about them. That's how refertotalgia came into being. What next? Past or medical history? Next.
Sir, any history of any radiation?
Your moderators are there.
Sir, history of any radiation to head and neck region?
No, बेटा पास्ट में रेडिएशन कहाँ से आ गया? पास्ट में हम क्या बोलते हैं हर बार? सर
in past, that is in the past history between about the if there any other swelling before that it may be so that any other small swelling was there which are excised but not properly documented. That is the important past history. And other important past history, then medical problem was there. In the mean, here in the past history, in the, any radiation for the any other cause or any swelling in the tongue previously which has maybe operated and not documented properly, maybe.
So these are very important questions. Now next, personal history. What is very, very important about personal history?
Tobacco history.
Excellent. Addictions. Which addictions? Pan, gutka, chewing. What else? Next.
Smoking history, sir.
Smoking. Wonderful.
And
Next.
chewing, tobacco chewing.
Okay, next. Whatever comes to your mind.
So it's reverse smoking and smoking.
Reverse smoking, tobacco chewing. What else?
Alcoholic history.
Excellent. So our question is, तुम शराब पीते थे हाँ या ना? Is that enough? तुम सिगरेट पीते थे हाँ या ना? Is that
You
enough?
have to quantify it.
Yes. So qualifying it doesn't suffice. Quantify it. That's how you get marks. वाह सर को बताओ. How do you
Smoking,
quantify it?
We quantify it by pack years.
Wonderful.
And alcoholic history in ounces taken per day and in month, or if it's regular or irregular or occasional.
So what is pack year?
Diabetes,
Next. What is a pack year? We are 3 more minutes into history. Rapid fire. Next. What is a pack year?
Sorry.
Anybody? बताओ दो. Next दो.
Total number of cigarettes smoked divided by the total number of cigarettes in one pack into total number of years smoked.
Yes. Who will tell me which study proved that there is a relation between number of cigarettes you have smoked versus developing of cancer?
Doll and Hill.
Excellent. Wonderful. See, distinction ऐसे मिलती है टक. हाँ. What next? So mechanism of carcinogenesis, we are not going to waste time on that, but this is a question that will be asked to you. How does smoking cause cancer? Just saying smoking is not good enough. How does alcohol exacerbate the effects of smoking? You will have to answer even that, right? It's all available in the sheet that we are going to provide to you at the end. What next? So this is your patient. He is giving you history of tobacco chewing, betel nut, smoking and alcohol intake. It's not present. Now we come to the history is over. Before, some examiners may ask you, summarize your history. Just say the salient positive history with personal history. Do not go into all the negative history. That's all. And then you start the examination part. Examination is being discussed by Sir Dr. Pal sir, right? So please talk to sir. How you examine this patient?
Sir, general physical examination. Patient is conscious, oriented to time, place and person, and patient has average build and moderately nourished, and patient's vitals are stable, and patient's functional status we have to mention.
Excellent. So remember, head and neck cancer ka case kar rahe ho. You are not doing normal case. So you always will talk about the functional status of the patient. Next. Everybody gets a chance. So functional status is defined by
ECOG score or Karnofsky score.
ECOG and Karnofsky. Next. Wonderful.
I think if you remember one, that is good enough. And please don't go to the examination without memorizing at least one of these two. ECOG is an easier one to remember. So you remember that because you will have one long case and 2 short cases. Out of this, at least one of them will be a tumor case. So you will be needing this ECOG scoring. So don't go to the exam hall without reading up.
That is small.
And more or less, once you are starting with your examination, your teacher, he also has to examine a lot of people. He is going to tell, go to the salient features. But अगर कोई बोल दे systemic examination, basic, you don't have to fumble with that. Say the pre-formed set of words that you need to say. These are the preset form of words you need to utter out. Say them and rapidly go to the next point. The next point will be examination.
Examination.
Define how you do that.
Sir, I will start with examination of the oral cavity. That will start with the external framework, looking at the lips and the angle of the mouth, the philtrum. Then I will ask the patient to open the mouth and assess his mouth opening, if there is any restricted mouth opening or not. I will ask if how much was the admittance of the fingers before he noticed that there was an evidence of restricted mouth opening. Then I will ask the patient to protrude his tongue and check if there is any restriction of the mobility of the tongue. Then I will ask the patient, then I will locate the ulcer and look at the characteristics of the ulcer.
Next, let him. So she is told something very, very important. Don't jump into the mouth and start saying, tongue mein ulcer hai. Before you go in, talk about trismus. Know the grading of trismus. Talk about ankyloglossia. Talk about the nicotine staining of the teeth. And then only go to the ulcer per se. How do you describe an ulcer?
Sir, first size and size of the ulcer, margins and its base, duration of the base, irregular, smooth, and
that's it. Okay, next.
What are the points? You just tell what are the points if you see, automatically you will fill up the blanks.
The site, the size of the ulcer, the nature of the ulcer, whether the borders are regular or those are irregular in shape, whether the margins are rolled out or excavated, whether the base of the ulcer is visible or it is filled with necrotic debris or anything.
Third point.
See, I'll just add a comment over here. Some of you are fumbling. It's not that you don't know how to describe an ulcer. It's just that you're fumbling in a public platform over here. In the exam hall also you'll be fumbling. A good way to overcome this is to remember or to list out the points that will determine the stage. Okay, so this is obviously a tumor case. So if you know the TNM staging, then all the points that will determine the T stage should be covered by you. Don't miss out any of those points when you are describing the ulcer or a growth anywhere if you have a laryngeal growth, whatever. Don't miss out the points that determine the T stage. When you're examining the neck, see you'll also get a short case. The general format is that in a long case you talk to the patient, take a detailed history. In a short case, you're not supposed to talk to the patient. You're just told examine the patient's larynx, examine the patient's oral cavity. You'll be asked to examine a particular site. So there also, if you have asked to examine the patient's oral cavity, you examine the mouth. Don't forget to examine the neck because the neck will determine the TNM stage. So all the points here, the first girl, she mentioned about trismus. See, if you get trismus, I appreciate that. Trismus, once you get trismus, it's T4B, okay? So T4A. Once you get the ankyloglossia, movement of tongue, again, it's T4A. Size.
The induration has also been mentioned.
Yes, exactly. The size has to be mentioned in terms of induration, not in terms of the size of the ulcer, because the induration is the size of the tumor.
Sir, in case of a short case also, when we are asked to present the case in front of the examiner, first we will be starting with distinct points, like I'll start with the inspection followed by...
The first question that you will be asked is, what is your provisional diagnosis? In a short case, the first question you will be asked is, what is your provisional diagnosis? Once you tell your diagnosis, then the questioning starts.
In fact, you've told everything. You've told everything that was on the slide except one thing, the location of it.
Protrusion.
How far is it from any particular landmark?
Yes.
You do need to tell that. I have to determine, is this lesion on the floor of the mouth. So you're doing an inspection right now, you're not touched it, right?
Yes.
Floor of mouth में तो नहीं गया, base of tongue में तो नहीं गया. Has it come on to the alveolus? So you have to give its dimensions according to the preset landmarks. There's only one preset landmark around you. What? The tip of the tongue you can see, the circumvallate papillae you can see, and the teeth you can see.
Base of the tongue is not entirely.
So do comment on that. And this is the best advice somebody could have given you in this entire exam season. The T&M staging. Size से बदलता है, depth of invasion से बदलता है. अगर ये नहीं बताया, you're wrong. The 3 and the 4. The 3 and 4 means some superficial or a deep invasion into the socket and the bone, eventually the bone, the loosening of the teeth, है कि नहीं है, teeth कैसा है, and eventually the trismus, masseteric space में गया कि नहीं गया.
For all examination, detailing of the examination, always start with like UG, inspection, palpation, percussion, auscultation in that format. So you not forget to detailing the word. Here no question the percussion or auscultation, but inspection and palpation. Where possible percussion and auscultation, you describe in this format.
So next, now we have to rush through the examination part. Inspection हो गया, what next? Add क्या करना है?
Then we'll move on to palpation. First, we'll check whether there's tenderness present over the ulcerated surface or not. If the patient complies, then we'll palpate and get an accurate size of the ulcer that is
This
present.
is very important. A patient is sitting in front of you with severe pain, and if you're trying to, नहीं मैं तो करके रहूँगा, that's not appreciated, right?
Yeah, once we get the size, then we'll look for the surface. We describe the surface. In this case, it can be irregular or rough. Then consistency and margins. Next, we need to look for whether the lesion has crossed the midline or not, followed by the edges, whether it's rolled out edges or not, and whether induration is present or not. Lastly, we'll look for the floor of the lesion that is present, whether there is a slough present or a granulation tissue is present. Then we'll look for any extension into the deeper spaces, floor of the mouth or retromolar region in this area.
Wonderful, good answer.
Yeah. Another point of view, see, I said don't miss out any of the points that determine the T&M staging. There is a ulcer of the tongue, you said floor of the mouth, you'll check. You'll also check its attachment to the mandible.
Yeah. Yes, sir.
Fixity of the tongue, the mobility of the tongue you'll check. Because these will determine whether it's T3, T4A or T4B.
Or T4B. Yeah.
Next, I will check the buccal mucosa, whether it is healthy or not.
No.
Then,
so we'll skip this part. Just don't focus on the affected part. Also talk about the unaffected parts. Right? Yes. Then you go on to?
Then I will go to
the end part of TNM.
Neck examination. I will first inspect whether there is any swelling or lump in the neck, and the size and shape, location, and the margin and skin over the swelling.
Those are standard answers. Sir ने क्या बताया? What changes the end staging? Only two things change the end staging. One is the size. Second?
Site and
nope, the site does not change.
Depth. Mobility of the
number. चलो ठीक है, number does change the end stage. What else changes the end stage? N3B. External extension. इन चीजों को मिस नहीं करना. Rest everything is standard set format. Do not miss out on site, size, number, and last क्या? Extranodal extension. If there is fixicity, it is straight away N3B, right? I am not going to teach. We are not going to teach you the end staging. Please read that. So summarize. Who's going to summarize? Summarize.
A 64-year-old male present in the OPD with pain in the mouth, and ulcerative lesion on the right lateral, the left lateral aspect of the tongue. Pain was associated with referred otalgia for 4 months with a history of tobacco chewing and tobacco and betel nut chewing for 30 years. On examination, tender ulceroproliferative growth of size 3 cm into 1 cm with everted and rolled out edges. Indurated base was felt, which bleeds on touch.
Hence, my provisional diagnosis is.
My provisional diagnosis is a carcinoma.
मैंने क्या लिखा? नहीं, carcinoma कैसे? Biopsy हो गई? It's a clinically malignant growth.
T3.
Unless you've done a biopsy, it can never be cancer. It is a clinically malignant growth. Clinically, it gives you all the hints, right? So it's a clinically malignant growth, oral cavity, likely carcinoma subsite, carcinoma oral cavity, subsite. Always say the site first, subsite, right lateral border of tongue. The likely staging is, क्या था? Next, likely staging.
Sir, T1.
हमने देखा ना अभी, पढ़ा ना?
Neck node wasn't there, so N0 and size was T.
It was less than 4 centimeters. The depth of invasion was less than 1 centimeter. So likely T2. Next. So important point. They've started talking about this DOI part. What is DOI versus tumor thickness?
So depth of invasion.
Versus tumor thickness. So what is DOI? What is tumor thickness? वो लिखते हैं ना DOI less than equal to 5 mm. क्या होता है? हाँ हाँ, पर क्या होता है? नेक्स्ट सबका नंबर आएगा. We are very short on time, तो rapid fire हाँ.
Tumor thickness is the growth of tumor from the surface of the skin, and the depth of invasion, it indicates the tumor thickness plus the area of the involvement of the tumor inside of the skin.
The invasion of the tumor into the underlying structure is the depth of invasion, which has a prognostic value. The exophytic component of it, which now makes it tumor thickness, has no prognostic value. That's the answer. So, इसलिए we talk about depth of invasion, right? Your DDs are next. We have come to investigation. Sir, investigation just after this. So, DDs are, I already show you. I keep leaking the exam.
Squamous carcinoma.
Because it is the commonest etiology. Next.
Verrucous carcinoma, undifferentiated carcinoma,
Don't write.
carcinoma of minor salivary gland, traumatic ulcer.
Wonderful. So workup. Now, Dr. Karanjay say we will be discussing what is the workup of this patient. Who's next?
We will go for.
How do you work up this patient?
Sir, we will go for MRI.
You like to go for an MRI first. You?
Sir, I would like to do a MRI first.
So imaging first or biopsy first?
Imaging first.
We'll ask our
imaging first.
Panelist.
In this case, what will you do? Imaging first or biopsy first?
Imaging first. MRI, I will do a content.
So in very small lesions, you do an imaging first. But if the lesion is quite large, it's quite alright to do a biopsy first. Because if there is a small lesion, then if you do imaging after that biopsy, then it will upstage the disease. So it does not matter if you do imaging first or biopsy first here, but I think biopsy first will do. Okay. And what biopsy will you take?
Punch biopsy.
How can you say punch biopsy when the answer is written right in front of you?
Wedge biopsy. Incisional biopsy or wedge biopsy?
But why wedge? Why not punch? Since you've said punch. Next. He said punch. Why not punch?
Sir, wedge biopsy because we need tumor tissue as well as a normal tissue also.
Tumor tissue and normal tissue is not really my concern. If I have a good pathologist, he'll find out the tissue.
Because also depth of invasion also. Sir.
Yes. I want to see the basement membrane. I just don't want the necrotic tissue that is coming out. The exophytic component is going to have the necrotic tissue. वो बोलेगा necrosis. There is another 7 more days of delay because then I have to go back again in. So I need the basement membrane. Yes. Next.
And
what
from
else?
what site will you take the biopsy?
From the margin, sir.
From the interface of the normal tissue and the tumor tissue, the most representative area of the tumor. Okay.
Yes, most representative area.
And how deep should the biopsy be?
How deep? Depth of more than 1 centimeter.
Let me put it differently. How will you know that the biopsy has been deep enough? That's right. Till you get bleeding. You should get bleeding after the biopsy.
In case of lateral border margin, ulcer in the lateral border of the tongue, in which side, medial side, lateral side, anterior side, posterior side, from which side you will take the biopsy? Is it lateral border ulcer?
Yes, sir.
It is a posterior surface, the anterior surface, medial surface, lateral surface, and which surface you will take the biopsy?
Sir, anteromedial.
Next. It doesn't matter.
Medial,
Who knows the answer? Biopsy कहाँ से लेना चाहिए?
Medial, sir.
Medial surface.
Or the advantage of the medial or the disadvantage of the medial? If you take from the medial and definitely whenever you take biopsy, you make a breakout point. So in the medial, if you take biopsy, easily it may cross the midline and totally prognosis and the TNF staging will differ.
See, answer is quite simple. Everything is driven by logic. If I have to take a biopsy, what is my main intention? Prove malignancy. Can I prove malignancy from any side? Absolutely yes. Then what changes? My convenience. Base of tongue में है, how will I stop the bleeding? It's easier for me to take it from the anterior end. End में aim क्या है? To prove it's a malignancy. Treatment तो बाद में decide होगा ना. That's how. Your convenience. You should not upstage or downstage the disease. You should be able to do a good hemostasis after you've taken a biopsy. Okay? And you should get a good result out of it.
Sir, if I take from the anterior side, it is more safe because you can exercise the anterior part.
Yes.
If the posterior part, it will go to the base of the tongue. In the medial, it will go to the anterior part is the most safe. If you grow in the some millimeter, you can chop it out during the operation.
And you don't talk only about the primary site. You also talk about the metastatic workup in the same breath. Don't say, मैं MRI कराऊंगा and stop there. Talk about biopsy, MRI and the metastatic workup in the same breath. So we know you know the answer. NCCN guidelines gives it to you very nicely. Now you said you get an MRI done. Why MRI? Why not CT? Next person. Why CT? Why MRI? Why not CT?
Sir, MRI will delineate the soft tissues better.
Excellent. Next. Why not CT? And why CT? Sometimes I may require CT more than I require MRI because.
So bone involvement.
Excellent.
Is better find out in the CT.
Sir, would you like to add, sir? Why CT one MRI? Bony invasion. Answer is CT.
Extra nodal.
What specific things will you see in an MRI of the tongue?
Sir,
in a malignancy case.
We will see the diseased tissue and the normal tissue which
yes, you will see whether it is operable or inoperable. That is the main. So what are the criteria of inoperability in an imaging? The disease which is such and such places, then it is inoperable. What are those sites?
Inoperable. So it is crossing the midline.
Crossing midline is not inoperable. It is eminently.
Okay. I'll help to cut it short. See, I am left with only 5 minutes and we have to reach the management as well. So radiology में, it's not adequate just to say MRI. MRI हम क्यों कर रहे हैं? Because I want a soft tissue delineation. I want to see the depth of invasion, the third dimension, right? That's important for me. And I want to see the bone marrow invasion if it has come anteriorly. But every once in a while, I would also like to know about if there is erosion, frank erosion of the bone, I would like a CT to complement my investigations. Otherwise, MRI is good enough. But what MRI? Difference क्या होता है? क्या-क्या sequence करा सकते हैं? Next. So what sequences do we get done? Okay, we'll tell you, sir.
T1 with contrast. T2.
So this is T1 with contrast.
Now you tell me why do you do T1 with contrast and why T2?
Sir, we have just 5 minutes. We'll not ask questions now. We'll just tell you the right answers. We are out of time. So
T1 is for just the baseline assessment with contrast whether it is enhancing or not, and T2 for better appreciation of the pathology.
See, there is enhancement. T1 will tell you enhancement. T2 weighted image. T2 tells you normal anatomy. So T2 tells you the soft tissue edema that is happening. So it will tell you the infiltration into the deeper tissue. A sagittal section versus a axial section, because sagittal में क्या दिखता है?
Tongue base. So the base of the tongue.
Axial में क्या दिखता है? Midline गया क्या नहीं? Depth of invasion. What is DWI ADC?
Diffusion already.
Not really required. ये distinction वाले के लिए. But diffusion weighted images and absolute diffusion coefficient. These are required. They help us differentiate between a solid tumor and the water component. So when the tumor is
malignant tumors.
Benign or malignant tumors, yes, the right answer.
value will be low in malignant tumors. It is sufficient to know that.
Yes, enough to know. The exact description is also given in the document that we have provided you. So T1 versus T2, you see there is some enhancement happening, but
It is mostly done in recurrent settings, not in.
How will you manage this patient? How will you manage this patient? The answer is surgery. What surgery?
Sir, glossectomy or involved in mandible and mastectomy also. Mandible.
Beta, see, when you mumble, you don't get marks. You may be wrong, but don't mumble. No, nahi karna hai. Clear answer.
Glossectomy, sir, or if the mandible is glossectomy, sir.
Glossectomy.
Or
पूरी जीभ निकाल दे.
Wide local excision, sir.
It's a T2 lesion. Will I remove the entire tongue? No. Give a right answer. Next. Next. Who's next?
Hemiglossectomy with or without neck dissection? Depending on the extent of the lesion.
Not in tongue. Everywhere else, one is enough. Not in tongue. Tongue may we go more. What else? 1.5. You don't need to. Exam may, you're not doing MCH right now. MS. Nobody is expecting you to say about margins. Say a wide local excision with adequate safe margins. Let it. Then somebody is going to ask you what is your evidence regarding 1 centimeter, 1.5 centimeters, 2 centimeters. Don't create your own gaddas. Say with adequate safe margins. Never miss out on talking about the neck. Do not say only the primary. And then the last part, काट दिया, जोड़ना भी है. Yes.
According to the pathology specimen, you decide if post of EBRT is necessary or not.
3 things need to be covered. काटना क्या है, कितना काटना है, neck handle करनी है क्या नहीं, and last बंद कैसे करना है. That's very very important, right? So mention these words right. How do you define glossectomies? Hundreds and hundreds of articles with different articles. The latest one which we all follow is Ansarin classification. Talk about Ansarin classification. Ansarin 1, 2, 3. You should know about the types of neck dissection. इसमें गड्ढा नहीं मारना. ये सुपराओमोइड नहीं पता है, lateral नहीं पता है. 1, 2, 3, 4 क्या है? आंसर देना है. N0 में करना है कि नहीं करना है. All examiners, if you are doing well and if you reached a stage कि N0 पे पहुंच गए, मतलब you already passed. फोटो खींचने का फायदा नहीं. I am giving you the presentation. I am giving you everything. So there is a good paper on this. If you are getting a distinction, we may come on to this. I have included this paper also in your reading. This is how Ansarin decided how am I going to classify my glossectomies. Based on मैंने काटा क्या है. Rectify this diagram, practice this diagram, irrespective of what question comes related to oral cavity, make this diagram. You will get marks. This is the N0 neck paper. Types of neck dissection, everything is included with you. उनका benefit क्या है, ये question भी पूछते हैं. What are the indications of adjuvant therapy? You will come to adjuvant therapy, read about it. Sir, I will summarize and finish it off. We are in the time. Okay, important thing. I thank all my moderators. I thank all my panelists. They have been working exhaustively for making a good presentation for you people so that you have a ready reckoner for your exams. Don't write anything, take this while you go back. Thank you.
Thank you, sir, for finishing our time. And I would like to thank the faculties as well for being on time and for such a wonderful session.